So I'd like to say just good afternoon to everyone. I am Ethel Massing. I am the president of the Indiana chapter of Inhimss. So on behalf of Inhimss and our entire board of directors, some of who are on this call, I'd like to welcome you to the call. So I hope you're all doing well. They're out there hunkering down, as our governor likes to say. I know after more than a month at home, I'm starting to forget what day of the week it is. But hey, I got earrings on today, so I am feeling a little bit more, like I made a little bit more progress. We have, so we have an amazing lineup of speakers for you today. And they're going to be sharing some insights actually on how well Hoosiers have been doing hunkering down. So our guests are from a variety of agencies, including IU's Richard Fairbanks School of Public Health, Regenstrief, Indiana Health Information Exchange, and the Management Performance Hub. And since I know they can do a much better job introducing themselves than I can, they'll do that before they speak today. Oh, it is not. There we go. Sorry. I have too many screens. So just a couple of housekeeping notes before we start today. This session is being recorded, and I'll be sending out a link to our general Inhimss membership, and I'll also post it on our chapter website. I did mute all your lines as you entered today, and we're just going to ask that you keep yourself muted during the call. Also, there will be a question and answer session at the end, and so if you have any questions, you can enter them directly in the Zoom group chat, and I will be monitoring those and answering them at the end of the call. And just if you want it to go to a specific person, just make sure you kind of note who you want the question to go to. So now, without further ado, we are going to start our presentations, and I believe Paul is going to start.
Great, thank you so much. See, Brian, if we can just get to slide 4. Yep. There you go. Yep. So I just wanted to say thank you, and I appreciate the opportunity to be with you today. I will tell you that I'm currently in my current role. I'm the founding dean at the Richard M. Fairbanks School of Public Health at Indianapolis campus, the IUPUI campus, and in our current configuration, we're spending a lot of our time. It's our honor to be supporting both the state health department and the Marion County Health Department and a variety of local health departments across the state. And it's especially an honor to be able to serve our hospitals and our work with the Indiana Hospital Association. You may know that we've been doing some work with, you can go to the next slide, it's fine. We've been doing some work with a number of you, in particular with modeling and I'm so glad that I'm on the call with both Brian and Nir, both of whom have been very involved with the development of surge anticipation surge models around both the disease and its impact, as well as its potential draw on critical hospital resources. So I spent my time before coming to Indiana as the founding dean to also be focused as the state health commissioner. I did that job as a member of the governor's cabinet, actually 2 different administrations, about 8 years as the state health commissioner. And then before that, I was at the Centers for Disease Control and Prevention as the director of the Division of Public Health Systems Development and Research. And in that role, I did a lot of work in the whole area around preparedness and response, in addition to a number of other things. This is actually a picture of the Emergency Operations Center that we designed and operated in Arkansas. And in fact, it's being used today, as you might imagine, focusing on the COVID-19 response. But it's my job today is to talk to you about reflections from practice. And I will also say, I'm a recovering hospital administrator. I spent the first 15 years of my career as a hospital administrator the last 7 or 8 as the CEO of a hospital in Michigan before going on to public health to get my doctoral degree. So I guess I continue to have a strong interest in practice, whether it's in hospitals or in public health. But my job today is to talk a little bit about the role from the decision-making and policymaker role, as well as the person has to operate and make things happen on behalf of the people. So go to the next slide, it'd be fine. So again, a lot of experience in incident command and working through a number of different both national and statewide disasters, including I ran one of the emergency operations centers at the Centers for Disease Control Prevention during 9/11 and anthrax, and then bioterrorism, chemical and nuclear preparedness, pandemic planning before anybody even knew what pandemics were. And then an incredible experience as the state health officer in terms of dealing with Hurricane Katrina and the many displaced residents. Too many tornadoes to count, and the list goes on, including H1N1. So it has there are a lot of similarities, but also big differences. Next slide. This experience has taught me that one of the biggest challenges in the Emergency Operations Center is actually situational awareness. You really need to get a picture of what the situation is that we face and know how fast and where the fire is burning. And I remember in that experience around Hurricane Katrina, we literally had over 75,000 people came to our state in big waves, and initially they were actually coming in military transport planes, and all we knew, we were sitting in the basement of the Emergency Operations Center. We had no idea. We had heard that people were in the air, people were in buses, people were in trucks, some people were in medical distress, and other people had different issues. The problem for us was without good information, it was very, very difficult. And so I think one of the most critical pieces of information, or why we need information, frankly, is to really deal with the issues around situational awareness, so you know what, where, how, what the dimensions are. And that's just really important. So having that radar screen that gives you a sense of what's really going on and what the evidence is to support those conclusions. Next slide. So it's really, and particularly in health and public health, it's not a problem where we don't have data. We just don't have enough meaningful information. So having the right data in a format that's intuitively consumable is so important. And again, it's usually not that we don't have the data. It's usually that it's not in the right form, or it's the wrong information, or not or incomplete information. We really do need to have at-a-glance indicators. The idiot lights are not usually very helpful, and certainly the big dense tables are not real helpful. You've got to be able to make decisions quickly, but having a good way in which to visualize the data is critical, and thank goodness we've gotten great. We've moved a long ways in terms of being able to better understand smart user interfaces and working with decision makers around good decision support tools. But again, that is really, really important, and I think that many of you in hospitals in particular have, I think, done a good job in terms of being able to get that information in a public health emergency where you're trying to run many different aspects of the disaster, if you will. Having good sentinel indicators is really important. We really need to show relationships between critical data elements without requiring manual calculation or look back. And I remember a lot of time in an emergency operations center, I was looking for something and they'd say, well, all you have to do is add page 3 and add page 4 and that'll give you what you need. Well, I don't want to do that. If it's possible for somebody to do it or a machine or a routine to calculate it, then that's really what's important. So we really do need to think through, and again, most of this is best done in advance, but sometimes you have to do it on the fly. So it's not always the case that it's really that complicated of information. It's just really being able to understand and look at things like, for example, ICU beds and available ventilators. Having those two measures together are really important and being aware the information's at and its relationship to each other is really important. And then showing trends over time and actual now numbers is really important. And again, it's not a matter of more is better. It's a matter of having the right data at the right time in the right relationship, and understanding the context that the decision maker is looking for is really, really critical. Again, this isn't rocket science. You probably face this every day in your daily work, and it's really just applied within the context of the emergency. In this case, next slide. I think the issue that's important is, for me, it's the epiphany, is that people who didn't get the importance of sharing data will have an epiphany when they just don't have it. And we find this to be true whether it was at CDC or in Arkansas, and certainly here in Indiana. It's always the case that there are people that don't quite understand why we need to share data. Data is proprietary, data is our competitive advantage, and so forth and so on. But we recognize in an emergency that if we don't have everyone's data, it's hard to make conclusions that really allow us to make informed decisions. And so my experience has been in public health that it's in the middle of a disaster that you recognize, and it's not just the people in public health, it's the people that are in hospitals that need to make decisions that because they didn't participate perhaps in a full and comparative way, that they then lack critical pieces of information. So be ready for the epiphany and be ready to figure out ways in which you can assimilate the data into the system, although again it's important to be able to have emergency access as well, and that's one of the ways in which we were able to resolve some of the people that didn't want to put information in. Was we had in case of emergency, break glass sort of approach, and so that's also a strategy, not as good as having everybody in, but if you need it to be there, it can be. And the reality is that incomplete information doesn't allow you to get the full picture, so having that is really important. Next slide. So the other thing I would say, and I'm wrapping up here, is don't get ahead of your skis. The idea here is that new artificial intelligence apps are great, but sometimes you just need a bed count. And it's amazing to me, and this has happened in almost every circumstance in Instant Command, where somebody who is really, really sharp in information management will come and they'll have some really new fancy artificial intelligence app that does all these kinds of things. And that's nice, but at the end of the day, we really do need to get some basic information that the decision maker needs almost immediately, and then when there's time, being able to do the creative, innovative things is really good. But having good, solid data in a format that's usable is really more important. And so what you can do is different than what it might be needed, again, at least initially. So I would just say to all my colleagues, and please don't take offense at it, but sometimes the most elegant models are not nearly as important as just good, solid numbers that you can count on and that they're in the right place. And in conclusion, last slide, don't let a good epidemic pass us by. And I say this because we've seen so often in public health that we suffer from inadequate resources, particularly in the area around public health informatics. So the critical nature of data to public health is so obvious to all of us now. There's an absolute need for advocacy to build public health informatics within a strong public health infrastructure for our state. And I say that from the perspective of In Indiana, we're ranked 47th out of 50 states in terms of our per capita investment in public health. We are asking a public health system that was never designed to do what it's doing now to do it well and without flaw. And frankly, this is a horrible time for public health because they could do more, they could do better, they're doing great. But the reality is that we don't have the infrastructure that we need to do this job as well as it could be done. The reality is that public health is best when we can prepare and be able to respond in partnership with our community and our partners. So let's not have this regret where we said if only we had this or that. We're making the best of it now, but let's use this as an opportunity to build strong public health infrastructure, including the strong information infrastructure in terms of our public health informatics, which are so vital to the success of what we're doing. So before I end, I will just say thank you for the opportunity, but thank you most of all for all that you're doing in your hospitals across the state and in the organizations that work to support hospitals, because I know that they're up against a really tough enemy right now, which is this virus. And I still don't believe that we have seen the worst of it. And you'll see perhaps with Brian and others some of the work that we've been doing on modeling. And I hope I'm wrong, but I do know that we need to work together, and I appreciate everyone's cooperation. Thank you for the opportunity to present.
All right, that's my cue. I'm Nir Menakemi, and I'm going to talk a little bit about some of the modeling that we have been doing, and I think it nicely dovetails off of what Dr. Halverson was talking about, that decision makers ultimately need actionable information. As he mentioned, we have been doing models for the state overall. We've been doing it by district for some of the larger individual counties. We've been doing it for some of them, but most importantly, we've also been doing it for individual facilities and for health systems. And I'll talk a little bit about what has gone into those models. And admittedly, Brian Dixon has been the key person that has reverse engineered CDC models that were originally designed to predict flu epidemics. For lack of a better term, we hacked the tools that were available. And one of the nice things about federal tools is they are hackable and allowable for those purposes. Once they're in the public domain, they're allowed to be used. We loaded up a lot of new assumptions into those models and cross-referenced with the CDC to make sure that we weren't stepping beyond sort of the reach of what these tools could originally be doing. And then from there sort of began running these models and assisting decision makers with real information that's simple and easy to act upon. Next slide, please. So this is my crystal ball slide where I like to say all models at the end of the day are attempting, for better or for worse, to predict the future. And if you're ever in the business of predicting the future, that's really hard work. Assumptions in the models are really, really important. And I think for those of us watching TV and listening to the debates and the pundits and all the different, news announcements, people are really confused about what models are and what they're doing and why did they change and why did the model say yesterday this many people were going to die and now we just saved 30,000 lives just by changing an assumption in the model. That can't possibly be right. There is no one size fits all. And models are ultimately, and this is my last bullet point here, are designed to assist decision makers. And everything that Paul was talking about was exactly right. Models will always have uncertainty, and big decisions will always have uncertainty. Models are just trying to make it a little bit easier to plan for that uncertainty. Next slide, please. So in our models, and again, we've taken these flu surge models developed by CDC and then re-engineered all of the different assumptions to work for COVID. And there's really 4 main categories of assumptions. And we've kind of organized them here as things that talk about the infectivity of the virus, and many of these things here on your screen are epidemiological terms that we kind of input into the model. And the way our team has sort of inputted these numbers is we went around first when information from China were coming out, and then from Italy, and then eventually from the US, from the CDC. We got best guess information about each of these things that measure how quickly the infection is ultimately moving through a population. So the attack rate is something, the reproduction number is another thing. Doubling times is something we hear a lot about on TV, where at first we were doubling every 2 to 3 days. We eventually slowed down to double every 4 to 5. Maybe we're doubling every 6 days. Slowing down on the doubling time obviously means the rate of infection is going down. Next slide. So the second thing we need to model, or at least put inputs into the model, is what kind of impact is this going to have on people? And again, scouring the literature, updating it as new information becomes available, keeping absolutely up to speed on the latest and greatest science on how many people are getting infected, of them, how many need to be hospitalized, of them, how many need an intensive care bed, of them, how many need a ventilator, what proportion of people are dying. And this is very challenging in the absence of ultimately being able to have a reliable denominator. Until we don't have a really good sense of who's infected asymptomatically, it's very difficult to get precise estimates, but nevertheless, you got to do with the best you can. Next slide. So these items over here, I want to come back to this infectivity issue, are all things that could be impacted by social distancing. And so if social distancing works, you'd expect the doubling time, the reproduction number to go down, and you would expect the length of the outbreak to increase. And so the whole idea of flattening the curve means you go from a very acute outbreak to a prolonged one, which is good, in part because the longer the outbreak takes, the less likely you are to overwhelm the resources that are available, which is item number 3. Next slide. The resources that are available is basically the hospital capacity. And these are how many beds do we have that are med-surg, how many ICU beds, how many ventilators, what proportion of these are being already in use at the beginning of the outbreak. And we're seeing a lot of national news about sort of the silent victims of the COVID situation are people with good old-fashioned regular health issues that either are unable to, are unwilling to, or are discouraged for one reason or another from accessing care. And we've seen now increases in deaths from things that, you know, we believe we could do a much better job on if we were not battling simultaneously a pandemic. Next slide. And then the fourth thing the models have to take into consideration is the characteristics of the population that will be potentially affected. And so if you're doing this at the state level, which we do frequently, we need to know how many people are in each age category, in part because all of the assumptions on how humans are impacted differ by age. They also differ by comorbidities. And we need to know, at least at the facility level or the district level or at the county level, what proportion of the population within the state is attributable to that lower level. So with the county, it's obviously easy. It's everyone in the county. In a district, same thing, everyone in the district. But what do you do if you have 3 hospitals in a given market? We have to figure out how to attribute the risk of each market share of each hospital to the population that they would ultimately have if we're able to make good decisions. And so our assumption has been, if we take the existing inpatient market share of a given facility and multiply it by the population stratified by age, that will allow us to sort of figure out if referral patterns continue under COVID as they did before COVID, who might go to what hospital. And obviously hospitals and facilities measure their markets differently. For some it's just the county, for some it's, you know, a bunch of zip codes, for some it's, you know, different counties and different zip codes across state lines. And so getting that right is really important for the models to produce valid results. Next slide, please. So what has changed since we started doing this? And obviously we've updated the models as we go along. We have different versions of the models and have run this as many as once a week for the state, the counties, the districts, sometimes more frequently for some of the larger systems, but about once a week when we can. The ICU rate increased, so when we first were looking at data from China and Italy, about 50% of hospitalized patients needed an ICU bed. Now, based on information we have from Indiana, we've kind of updated it to probably closer to 90%. And again, if this information is ultimately designed to make decision makers able to act, you need to constantly make sure that the models are producing information that are most relevant to the current situation at hand. And this is what I think Paul was describing as now data, which is why this is important. Length of stay decreased. When we were looking at data from the world stage, lengths of stay were much longer. We believe they're a little bit shorter in Indiana as observed, and in the US overall compared to some other parts of the world. And so how long you're going to stay in a bed affects the model's ability to predict how much resources you will have in different time frames moving forward. Next slide. And so changing these things does not change the number of people that will be affected. It changes the amount of resources that might be available. And that's something that some of the work that we have been doing with individual support calls to hospital leaders, including CEOs and other C-suite members, where sometimes it's not as clear when we tweak something to the model, nothing changed from their perspective, or at least on the item that mattered to their decision most, and they wanted clarification. And so we said sometimes the things matter to utilization as opposed to the number of people. So if all you care about is the number of people, this change might not affect you. Next slide. We also learned, as we had sort of moved along with this project, that when the surge or the curve or the outbreak or the epidemic started does not equal exactly the same time period for every single place that we have studied. And so I think this was erroneously discussed at the national level, and then people quickly realized that New York and Washington, for example, might be on the leading edge of some of the curves. Other states, perhaps in the Midwest, were lagging. Perhaps in the South and other regions were lagging behind that. And we started noticing that the same exact thing was happening within the state. District 5, which is the greater Indianapolis area in central Indiana, appears to have started before the other districts within the state. And it would be erroneous to assume that everyone's moving across the curves in the same pace, in part because it became very obvious to us that some people were staying in week 1 for a very long period of time until they hit a critical mass, and then the model predictions kind of kicked in. Next slide. Death rates also decreased, the proportion of people who were ultimately infected as we got better and better testing. In particular, an article in The Lancet came out that helped us upgrade our model's assumptions. Next slide. And the doubling time, as I mentioned, slowed. One more. And these two things affect the number of predicted patients. If we're going to predict how many patients need an ICU bed or a hospital bed or might die or need a ventilator, changing these assumptions literally changes the quantity of people being predicted. And so there are a lot of moving parts to the models. Next slide. So this is a super simplified version of what our output from each of the models look like. What you see here are the curves that we had predicted, 5-6 weeks ago now, that would occur by district. You could see the districts of the state that the Indiana State Department of Health uses. The big tall one is District 5 at Central Indiana, and then you can see the other ones have been predicted to peak at 1 to 3 weeks behind where District 5 was supposed to. If you're particularly astute, you realize that where the models have predicted we'd be right now is at the peak, and that's give or take about what we have seen with some caveats. I think when Brian is going to sort of take over the conversation, he'll give some tantalizing early evidence that the social distancing has potentially been working. We're still kind of trying to fully understand whether or not that is the attributable cause to some of the shifts to the predictions. And I'll let him talk about it. But another important thing about the data, and this goes back to Paul's point of things change fast in real time. And on day one of, the epidemic, the people who are being hospitalized and even moved to intensive care are not the same people in look and feel that they are now. As the emergency departments have gotten more comfortable with this, as people have burned through PPE, as people have sort of began to just be comfortable managing COVID inpatient and otherwise, they have been perhaps more comfortable sending people home instead of into a bed. Whereas 5 weeks ago, that person would have had a bed, no question about it. Now it's like, go home and call us if you need it. Your pulse ox was probably fine. You're okay to go. We feel more confident in what might happen to you now than we did 6 weeks ago. And so the curve potentially flattening might be a combination of both of those things. I'll let you guys kind of chat a little bit about that, but I'll advance to the next slide.
Good afternoon. This is Drew Richardson, Vice President of Business Development. I work very closely with our sales, project management, and our new product development team, which includes a lot of population health and public health capabilities. And so I've been part of our coordinating team at iHi to help with the COVID response. And so what I want to do is go through, Brian, if you could advance to the next one, I'm going to talk through about 6 different projects that iHi has been involved in. These are more specifically as a state response level. We've been working very closely with our individual customers for their immediate needs. So if an organization has a need, they've come to us, whether that's a COVID-related response for data or something else, we've been able to handle those as well. But what I want to do is highlight a few of the areas is where iHi has been a data provider. And I think Nir and Paul both talked a lot about that component of it. But the infrastructure that was set up here in the state, I think, really allowed the teams to be able to hit the ground running, to have the data assets that were here and already kind of formulated so that they could be able to start with the initial PPE type of discussions that were going on and some of the other kind of questions that quickly arose. So iHi has been providing to both the State Department of Health and Family and Social Services Administration both our ADT alerts and our clinical value report. So a lot of clinical data that helps to support the dashboards, both the state dashboard and the Regan Street dashboard that Brian will talk a little bit more about as well. Both the public-facing dashboard and a private-facing dashboard that's been really helpful to a Marion County Public Health Department and Indiana State Department of Health from an epidemiological perspective. We've also been supporting the state as it relates to the communicable notifiable condition detector. So there have been about 52 LOINC codes that are associated with COVID, and so we've been updating those codes on a regular basis as new codes get created to ensure that that information is flowing into ISDH, and so that information also flows into the INPC as well. So a valuable asset that we're being able to provide. One point to note about the ISDH LIMSnet data is a lot of the data is flowing from iHi to the state, but what's really been critical is the state has data that needs to flow back to iHi so it can be utilized for clinicians and other providers as they're trying to take care of those patients. And so if there was data that was flowing in through a Lilly lab or the LIMSnet data, this information wasn't necessarily getting any of the visibility to the health systems. And so what we were able to do was set up a data feed to receive that results from the State Department of Health. So all those lab results are coming into the INPC so that that information can be utilized both from a CareWeb application or from our modeling purposes. And so that's important to make sure that the numbers that Brian will talk about are as accurate as possible. So we're continuing to work on that piece of it as well. If you could advance the next one. One of the key pieces here is that iHigh has a pretty good representation across the state, but we don't have the entire state captured. And so one of the requests that came in was, iHigh, can you work with some of the facilities and organizations that are not sending data to the state or that are not sending the data to iHigh so it can come in a single consolidated view? And this has been really, really critical because iHigh takes a lot of that work to normalize the data and put it in a fashion that can be utilized for the modeling and for other purposes. So I think a lot of that time and energy to onboard those sources has been really, really valuable. We are working with about 5 to 10 new organizations right now. We took one live today, and we'll continue in the next coming weeks to continue to onboard new data sources. That's one of the things that I think Paul mentioned is we've got a unique opportunity here to have a single consolidated view. There were multiple HIEs, and now we're trying to get to a single HIE that can really provide that value from a state perspective. Continuing to talk to the state as it relates to a virtual care strategy to support the F2HCs, trying to provide information from a virtual care perspective to handle patients that may not need access to the healthcare facilities or the hospitals, but still need access to health care. And so these are able to provide ongoing care. So working to set up access to our longitudinal record of the INPC and provide some event notifications for those patients. And then the last piece I wanted to get into and then kick it off to Brian to talk a little bit about how the data is used is really one of the other projects we looked at is taking the addresses of all the long-term care facilities and trying to map that against the address of positive COVID patients. And so that we could provide some information specifically as it relates to long-term care, knowing that that is an area that's been hit pretty hard here recently, so that they could have some more identification and identify those patients that have been at risk or may be in a long-term care facility. And so iHigh's been working very diligently to fill the data sources, automate most of the outputs, so that all of the modeling researchers, clinicians can take and utilize those pieces of data. And we'll let Brian kind of kick off some of the dashboarding views that we've been working on.
Thanks, Drew. So I'm Brian Dixon, the Director of Public Health Informatics at Regenstrief and this Fairbanks School of Public Health, and in the epidemiology department there at the School of Public Health. So very quickly, just to make a couple of points, public health informatics year-round, the program I direct at the school in Regenstrief really tries to take informatics approaches and use those to support the field of public health. So we are, it's a busy time for us, but this is what we do as we support public health. And so we're very interested in seeing data and information be used in public health decision-making processes all the time, but particularly in this crisis. And that's really, I think, a theme that you've heard from the other speakers and really what all of us talking today are trying to do, including Jody, who's coming up next. So I think that really draws on our roots. A lot of people talk about John Snow as the first epidemiologist, the kind of grandfather of epidemiology, if you will, and that's really because he was interested in gathering individual data points and then sort of plotting them out to find the source of cholera outbreak right in London, and that's essentially what we're doing with all these projects. We're taking the data that iHigh is making available, that's gathering from some non-INPC institutions, and taking the data that come from these sort of drive-through clinics that pop up and kind of routing that through to public health authorities so that they can get a sense of what's happening, and of course health system leaders as well, to understand what's happening maybe in their community rather than just inside of their walls. So how are we leveraging particularly the health information exchange and other data assets to respond to COVID-19? There's really kind of two approaches that we've seen states take. One is, in some states, this is their setup. They've got a state health lab that can send electronic lab reports to the state health department so they can get some data in electronically. But for their health systems and their private health labs, they're relying on phone calls, faxes, paper records to be shared. And that is, of course, this is not the state here in Indiana, as you've just heard, but other states are taking that approach. Or what we're doing here is we're really leveraging our health information exchange infrastructure, which is a whole bunch of stuff that happens right in the middle that you just heard, several of the things you heard about from Drew, like the NCD that can detect information and route it to public health. But that's really the model that we'd like to see everyone move to who's not on this kind of platform today. And I think really the power that we have with interoperability and information systems in 2020 to get people to, especially if we make long-term investments in our public health infrastructure. So this is a public dashboard. Drew mentioned it. It's one that we started building right away as soon as we could. We started with the information we had available to us, the second week of March, and we've only added to it and pushed it out the door ever since then. And that is allowing individuals like yourselves, the other members of the C-suite at your institutions, and community stakeholders really have a better sense for what's happening to people inside of hospitals and sort of their comorbidities and other data associated with that visit. The official State Department of Health website has information on who's been diagnosed, who has died from this disease. It gives kind of those pieces of information that are really important at both a state level and county level. Our dashboard is designed to be complementary. We've built it in partnership with the State Department of Health and FSSA and the Governor's Office to focus on those things that really can be highlighted by the data in the IMPC and being captured by IHI to give people greater details, particularly around hospitalizations and ICU utilization. So that's what you see in this center graph is overall hospitalizations, discharges is the next line, then ICU admissions, and then ICU discharges over time, so we can keep an eye on that. Length of stay, I think, is really important. Stratified by age is even better because we've seen some interesting patterns, such as some younger people being hospitalized for longer. They have greater odds of survival, which we'll see. We're going to be adding death data to this in the coming weeks. But certainly from a length of stay perspective, they're utilizing more resources even than some of the older populations. And then, of course, down here in the bottom right are comorbidities, so we can start to get a sense for what are those diseases that might be contributing either to hospitalization and or longer lengths of stay. A corollary to the public dashboard is a private dashboard that actually allows us to drill down into details. This dashboard will allow you to look at zip code level analyses as well as drill down into individual cases. This dashboard is available for people who work in a public health organization. So county health departments, the State Department of Health Emergency Operations Center has access to this, and this is helpful for them to look at details around what's happening in different parts of the state, and again within a county. So Marion County, for example, is using this to look at what's going on inside of the county, not just what's happening at a county level. For example, some of the things they've been able to do with it so far is look at hospitalizations. So as you can see here, the top graph comes from Marion County. The bottom graphic comes from Lake County. Those are kind of the two of the main hotspots for COVID around the state. The length of stays are different in those different counties. And so that allows us, this dashboard allows us to identify what those differences might be, which then allow us to start to ask questions about why that might be so. Why are ICU lengths of stay so much longer in Marion County than they are
in Lake County, for example. Again, this is just amongst those patients who've been discharged to date. So allows answering some of those important questions. Similarly, the dashboard allows us to look at things like health disparities that public health departments care a lot about. So in Marion County, for example, they've been able to take the data from the dashboard, convert that to a rate per 100,000 lives in the community, and separate that by both age and, both by sex and by race. And they can see here on the top left graph, that's whites compared to blacks, and blacks have about twice impact in terms of number of cases diagnosed, hospitalizations, and deaths as opposed to whites. And then the bottom right graph compares males to females. So while cases are not that far apart in terms of diagnosis and hospitalizations are not that different in terms of their rates, the death rate is about twice that for men than it is for women. And so that allows us then, to ask the question, why is that? Why would males be more susceptible to death than women, even though they're contracting the disease at similar rates? Nir mentioned the models that we have produced. We're also using the IMPC data and the dashboards particularly to monitor hospitalizations over time in comparison with our predictions. So this graphic shows predicted hospitalizations for District 5, which is the Indianapolis and the Donut counties. And you can see that the red bars are the predicted rates. Again, our models initially did not assume any kind of social distancing. And you can see for the first few weeks, it tracked very, very closely to reality. We were predicting, for example, in week 4, around 600 hospitalizations, and we ended up with something more like 700. And then the rates kind of leveled off in week 5, which would have been that week that ended around Western Orthodox Easter, and then this past weekend, week 6, which is Eastern Orthodox Easter, the rates actually, we saw them decline in the center part of the state. And so that's fairly good evidence that social distancing has had an effect. Again, as Nir mentioned, though, there may be other underlying causes, and we're looking into that. But we have, at least now data that we can use to support looking into those types of questions. Another data resource we have access to is the EM resource system. Some of you may have heard of that. That's an information system that the Emergency Operations Center at the State Department of Health set up towards the beginning of this epidemic. In week 4, they went live in asking all hospitals to report number of COVID patients who were tested positive, number of COVID patients who are persons under investigation, PUIs, who are in regular hospital beds, med-surg beds, ICU beds, on ventilators. We can use that data as well to triangulate with the IMPC data. And again, those data weren't being reported in the first few weeks, but starting in week 4, you can see the numbers from EM Resource and IMPC for District 5 are pretty similar. There's slight differences, but they're pretty close together, and they're both pointing kind of in the same direction in terms of trends. We can look at the same thing statewide with the dashboard. So here again, the black line is from IMPC on hospitalizations, and the red bars were the predictions. First 5 weeks, we were pretty spot on, and now we've seen rates decline. Why were rates going down in central Indiana or flattening in central Indiana, but yet at the state level still going up? That's because those other regions of the state are slightly behind Indianapolis in terms of where they are on the epidemic curve. Similarly, if we look at EM resource data, we too see a similar pattern. Again, they began reporting or capturing that data in week 4, and we have it now through week 6, and there's a similar pattern of some, now seeing statewide declines, although most of that is being driven by District 5, where the population center is. The other thing we've been able to do is compare our model with other models. So some of you may have heard of the Institute for Health Metrics and Evaluation, which is out of the University of Washington. That's a model that's been talked a lot about in the popular press as well as national TV outlets and so forth. We plotted both their original prediction for the state, which is the yellow bars, the red bars are IU, our Fairbanks model, and then the green bars are the revised IHME model that they came out with on April 10th. That's the one, that's about the time that they started to get a lot of press because they had lowered all of their projections in terms of deaths and hospitalization. So you can see that green bar is both earlier in terms of when it was peaking and at a much lower level. You can see that based on the observations from both IMPC and EM Resource, the data fell, again, tracked fairly closely to our predicted models for the first 5 weeks, but more than that, they really fell within sort of that range of, if you will, of the different models. So every model has a confidence interval. These lines of observed rates are clearly within the confidence intervals, probably more so on the Fairbanks model, and maybe to some degree that original IHME model, maybe a little bit less so for the revised model, but nonetheless still kind of within their confidence intervals, which were fairly wide, but nonetheless tracking close to models, but of course reality is often different than what we forecast, as Nir talked about. We've also, some other initiatives very quickly, and then I'll turn things over to Jody, we've launched an effort to collect symptoms over time of the general public. So this is a general survey of the population. It complements any kind of RNA testing or antibody testing efforts that may be going on in the state, because it allows people to report whether they're have any symptoms or they have some symptoms. It allows them to report that. We're doing that in partnership with Microsoft to offer this survey on their MSN and Bing platforms in a somewhat but not quite randomized way. It's attached to some stories for a certain period of time, so it's not just like, hey, we want everybody on Twitter to go and fill this thing out, but trying to make sure that we get a representative sample from their populations that they serve. And that survey, by the way, is going globally this week in 30 different languages. We're also using this survey platform in a broader way in Indiana to complement other statewide activities, and potentially partnering with the Marion County Health Department in particular to do some survey work inside the county here in Indianapolis. Data from our dashboard will be publicly available starting next week after we have some initial results to share with the world. Other things we're working on and have started at Regenstrief in particular in partnership with the state is the Indiana Pandemic Information Collaborative. Some of you may be involved in that activity. Others may have heard about it. It's a coalition of the willing who want to respond to COVID and help work across organizations to minimize duplication of effort and improve communication across organizational boundaries. We've got a number of teams that are part of this collaborative, including a health systems team, a modeling team, a dashboarding team, and a team that's focused on data standards and interchange. Drew, Nir, myself are all part of these different teams and are part of this collaborative, and most of your organizations are likely already a part of it. If you're not, though, and you'd like to be, please just send us an email to Jennifer Williams, who's helping coordinate some of this. She can make sure you get added to it. We've got essentially phone calls almost every day of different team calls, larger group calls to coordinate efforts across United Way, across public health, across hospital systems, and it's been a really, I think, rewarding experience over the last sort of week and a half to 2 weeks that this has really been getting off the ground. So encourage you to look into it if you haven't already thought about it or have someone on your team who's participating in it. With that, I will stop and turn things over to Jody. Thanks.
Hey everyone, my name's Josie Fassel. I don't have slides, I apologize. And I won't be turning on my video because I have my head next to my speaker so that you can hear me very well. My name's Josie Fasselt. I work with the Management Performance Hub. I'm their Senior Director of Engagement and Analytics for Health and Human Services. We are an agency in state government that focus solely on data services and data-informed decision-making for our state government. Our agency has been in existence for nearly 3 years now, so it's possible that some of you on the call might not be aware of our work, and if not, I encourage you to check us out at our website, which I inserted into the chat. I've actually inserted several different resources into the chat that I would like for you all to take a look at if you haven't taken a look at them already over the past several weeks. Like everything that's been said on this call, we have also been extremely busy and have had amazing partnerships that have deepened and been strengthened, and it's just been absolutely amazing. Related to that, since March, we have been working with partners like IHI, ISDH, FSSA, Regenstrief, and others to bring together important data on a daily basis so that state policymakers and decision makers are updated with the most recent information on the epidemic. Some of the most intensive work that we've been doing is acquiring this data and connecting it at the individual level. And over the last several weeks, we've been able to acquire and bring together the ISDH NEDS-based system data, also referred to as the MBS data, which is the disease reporting and case management system information that we're pulling of confirmed COVID cases every day. We're pulling ISDH public health emergency surveillance data from their FES system for emergency department visit specific information. The ADT data that Drew referred to from hospitals, both from IHI and also Michiana Health Information Exchange. And also what Drew was referring to earlier, the critical vital report or CVR data from IHI. This linkage has been mostly used at the state as an effort just to really improve the data quality, especially around missing demographic information that was coming from various sources. And we've been able to work very speedily to put this data together so that we have better demographics of individuals who are testing positive for COVID. We've also been using the information to understand the emergency department and hospital usage of confirmed cases. We have a team of people that are on a state COVID response team that work with the governor's office every single day. We're also collaborating with Regenstrief and others on building data models and are monitoring results closely. Every day, the state's COVID response team looks at the data and we provide updated reports to the governor's office. And then lastly, because I want to make sure if you have questions, you have some time, I highly encourage you to check out that link that I put in the chat for the hub.mph.in.gov. We have been aggressively pushing COVID datasets out to our public hub with information that we've heard would be important. Paul earlier talked about just wanting to have the count of beds and vents, and we pushed that out yesterday late afternoon, and it's currently on our hub for you to check out. There you'll find 5 different data sets right now available to you. Some of them are aggregate at the county level or demographic level, and some of them are de-identified at the row level. We have COVID-19 case data that is stratified by report date, county of residence, age group, and sex. We have COVID-19 case demographic information that you might find useful. Again, the bed and vent information is out there from yesterday, and we have statewide test, case, and death trends that are reported every single day. So all of these are being uploaded every 24 hours so that you have the most recent information. And we really want to hear from you on data that you would find useful and important. I've put our Twitter in there as well, or a link to our Twitter, so that you can just directly go on there and tell us the information that you really need to see out in the public. Our motto is data to the people, and we want to make sure that we're producing data sets that are going to be valuable to data scientists, researchers, and also just the general public that's out there. So any questions, any information that you need, please let us know. You can either contact me directly or you can put it there in Twitter, and then we will follow up with you to see what we can do. And that's all for me so that other people can ask questions.
Gosh, thank you to everyone. We're running right up against time. I know I have a couple questions. There weren't too many in the chat box, but I just want to thank everyone so much for your participation in this call today. Really, really great information. Like I said, I will be posting this recording and sending the link out to our general population. I think I'll just ask you one quick question before we go, since we'll have a lot of, I actually have been getting emails from people who missed the call but want a recording. So one thing that I'll let you ask to them, obviously Health Information Management System Society is full of health informatics professionals. Is there something that people in these health systems can do to help you?
I'll start and then others can weigh in, but I would say, besides, taking a look at the data sets that Josie mentioned as being available, feel free to join our kind of pandemic collaborative and participate in the conversations. One of the things that I find most beneficial is just talking to other people. There are, modelers. I'm kind of the co-lead of the modeling group along with Patrick McGill, who's at Community. And one of the things that I find most interesting is just talking with others, because there are modelers and statisticians in every health system in the state, and they all have similar questions. And so we can talk across organizations and say, what are you seeing? What data are you using? What model are you using? And we talk through things together. Those same kinds of conversations are happening amongst community groups and health systems groups and the dashboarding group, because everyone's got a dashboard probably within their own institution. And many of the Inhimss members are probably building those dashboards or modifying those dashboards or doing those things. So that is an opportunity to learn and share with the community. I think that's helpful because we all are in this together. And so let's talk together and work together on solving the things that evolve, because this epidemic is not going away. We may be at a point where we can begin to relax some things and begin to return to whatever new normal might look like, but we're going to have flare-ups. We're going to have a resurgence probably later this year, and so we're going to all continue to need to work together to monitor the situation and address those things when they pop up again. So that's my response. I don't know if others want to weigh in.
This is true. I would just ask that if any of your organizations are not contributing data to the INPC, that we're always willing and able to take on new data sources. So that would be one of my pieces of it. And then also, if there are data assets that you need in order to support your efforts, whether it's modeling, and they may be de-identified, please reach out to MPH. If they're identified, please reach out to IHI. If you need assistance, I think all of the speakers here and others are willing and able to help in whatever way. I think the openness within the community has been absolutely fantastic, and I think that everybody's just doing a great job of collaboration. And I think if you've got needs, please reach out, because I think there's people willing to help.
Great. Well, again, I just want to thank you all and hope you have a great rest of your day. So thank you.
Thank you for the opportunity. Good to speak with you and your members today.
Yep, thank you.
Yes,
Thank
thank
you.
you.